Appreciate. Perfect. So my name is Carrie Racian. I'm a senior research scientist at the Yale School of Public Health, and I serve as the executive director for the Firearm Injury Prevention Initiative. Jointly with UConn Arms, we are proud to co-host this webinar series. On Target meets about once a month to provide an opportunity for dissemination and discussion about emerging gun injury prevention work. This seminar is open to all researchers, policymakers, practitioners, and just anyone who wants to know more about research in this field more broadly. If you'd like to present, please email us. UConn Arms will be the email. I'll drop that information in the chat once the presentation gets going, and we can discuss that further. But again, we really welcome presentations from any discipline, and we want this series to be multidisciplinary. So please let us know if you have something. So that you can mark your calendars, our next seminar will be on January 28th, and will feature Dr. Alexandra Middlewood, the department chair and assistant professor in the Department of Political Science at Wichita State University, and we'll drop an RSVP for that in the chat as well. But today's seminar, I am excited to welcome Dr. Ayesha Dholakia. Dr. Dholakia is a Pediatric Emergency Medicine Fellow at Boston Children's Hospital. She grew up in Sandy Hook, Connecticut, before studying neuroscience and public policy at Dartmouth College. She worked briefly as a foster care caseworker in New York City before going to medical school at the University of Chicago Pritzker School of Medicine. Her work focuses on firearm violence prevention, as well as on trauma-informed care and health equity broadly. Today, she will present Firearm Homicide in Pregnancy and the Postpartum Period, an overlooked crisis in maternal mortality. And in the event that you are new to this seminar, I've seen a few new folks, so this is really exciting. Dr. Dholakia will present for roughly 30 minutes, and then we'll open it up for Q&A. If you're somewhere that you can't talk and you need to pop something into the chat, please feel free to do that. I'll read it and moderate, but of course we welcome you to also come off mute and share your question yourself. So please feel free to do that when we get to that part. If there's something super urgent and that you just must clarify during the actual presentation, go ahead and just put that in the chat. I'll be monitoring the chat and we'll sort of interrupt as necessary, but we hope to save all of that for the end of the presentation. So without a moment more, I'm just going to turn it over to Dr. Dholakia. Ayesha, please take it away.
Thank you so much, Carrie. All right, let me share these slides. All right. Thank you all so much for having me and for tuning in today. Thank you again, Carrie, for that introduction. I'm very honored to have the chance to speak with all of you. So today I'm going to talk about firearm homicide in pregnancy and the postpartum period and discuss overall literature and data in this space, and then some specific references to a recent study that our team published this past month on this topic. All right, so when we talk about maternal mortality, we often picture medical complications, but for too many women, pregnancy ends not in childbirth, but rather in homicide. So these are several recent headlines just highlighting real people behind this talk, mothers whose stories briefly made the news and then disappeared as just kind of more statistics in this crisis that has gone under-recognized. So the first is Ina. She was 32 weeks pregnant, also had a toddler and was shot in her car. Tanya was killed by a partner at 8 months pregnant. In India was a woman killed on her due date, so the day she was set to be induced, and her baby didn't survive either. And these are just three of so many more pregnant women who should have been surrounded by support and hope. And instead, I would say pregnancy became their moment of greatest vulnerability. So just some quick caveats and definitions before we get into the data. Through this talk and in our study that I'll reference, you'll hear me use the term women, but I just want to quickly acknowledge that not all people who become pregnant identify as women. And I use it as the terminology that's used in NVDRS, which is the database we used in our study, and how we thus classified our variables. And then regarding the concept of maternal mortality, there are three related but distinct mortality categories in the literature that I just briefly wanted to point out in case you go and read more about the topic or you encounter it in the future. So I will most often use the term pregnancy associated as the most accurate description of homicide, since this includes any death during pregnancy or within a year postpartum, regardless of cause. So this is inclusive of homicides, of suicides, and of medical complications. In contrast, pregnancy-related death is a term that's used only in the United States and represents a subset of the pregnancy-associated deaths in that it only includes deaths from obstetric causes. Same time period, so over pregnancy or within 1 year after pregnancy, but only obstetric causes included. And then maternal mortality is the term you'll see used by the WHO and in international comparisons, and is defined as death while pregnant or within 42 days of the end of pregnancy. And so a more limited time period and from obstetric causes only. So I might use this term interchangeably accidentally, but just know that this is the technical definition. And so homicide is technically excluded from discussions on maternal mortality. Okay, so with those definitions in mind, I just want to zoom out for a second before addressing homicides and firearms specifically, and first ground us in where the United States sits on maternal mortality more broadly. So you can see in this figure compares maternal mortality ratios across several high-income countries. And so starting all the way here on the left side, you can see countries like New Zealand and Norway have death rates that are less than 2 per 100,000 live births. And then all the way on the right, you can see the United States in the orange at about 17 deaths per 100,000 live births. And so this kind of shows you we're not just a little worse, but rather we are a true outlier amongst our peer nations with mortality rates nearly 2 to 3 times minimum higher than that of the countries that are listed here. So this is from the Commonwealth Fund. It's a quote that shows that globally maternal mortality has been declining, but in 2023, out of all countries, the United States was one of only 7 countries to report a significant increase in the share of pregnancies that have ended in death over the past 2 decades. And so I present this just to show you the backdrop for this conversation. We are already doing very, very poorly on maternal health, even before we talk about violence and layer that piece onto things. Which brings us to this awful paradox that in one of the most medically advanced countries in the world, homicide and not hemorrhage, not hypertension, not sepsis, which are the top 3 medical causes of maternal mortality, all shown here in this bar chart. They're all shown here stacked next to homicide. Homicide itself is now the leading cause of death during pregnancy and the early postpartum period. And so in this graph, you can see the y-axis is deaths per 100,000 live births. And then you can see the various causes listed here. And you can see that homicide exceeded each of the leading causes of maternal mortality by over double or over 2-fold. So that's really striking, right? We invest, as we know, enormous resources in monitoring blood pressure and labs in pregnancy. But the greatest threat shown here to pregnant people is really not biology, but rather bullets. It's a preventable societal imposed threat. So in our study, we looked at national data from 2018 through 2021, and there were over 400 pregnancy-associated homicides across 37 states, which is more than 1 pregnant person killed every 4 days. And just to say, I'll talk about this in a little bit, but this is almost certainly a gross underestimate of the true death toll due to challenges that we have with ascertaining true pregnancy status. So again, I'll talk about that in a little bit, but of these homicides that we looked at, nearly 4 out of 5 involved a firearm, which you can see in this pie chart here. And that trend of firearms driving these overall homicides isn't driven by just 1 or 2 outlier states. When you look more granular state by state, of the 33 states that we looked at with non-zero data, firearms were involved in more than half of the pregnancy-associated homicides in 88% of these states. So that's the vast majority. In 2/3 of states, firearms caused more than 3/4 of those pregnancy-associated homicides. And in 1/3 of the states that we looked at, 90% or more of pregnancy-associated homicides were firearm homicides. And so when we talk about pregnancy-associated homicides in the United States, we really are talking about firearm homicides for the most part. And pregnancy itself is a risk factor. So in our study, we found that pregnant and postpartum individuals experienced a 37% higher firearm homicide rate as compared to their non-pregnant peers. And so again, a time that we imagine as protected is in reality a period of heightened vulnerability to lethal firearm violence. But the impact of these numbers is not felt equally. And so to zoom out a little bit again, the existing maternal mortality crisis is already profoundly unequal. This map shows overall, so not violence specific, but overall maternal mortality by state first. So here's our scale. White and light blue over here is kind of the lowest maternal mortality rates up to this dark purple, which is the highest. And so you can see that gradation across the country. This again is overall by all racial and ethnic groups. We then stratify by race with this left graph showing rates among white individuals and the right showing those for Black individuals. And so again, you can see before we even introduce homicide into the equation, Black women, especially in certain states, are already at a dramatically higher baseline risk of dying in pregnancy. And just to note, these are a couple of the maps that I pulled from the study, but there are also higher homicide rates in American Indian and Alaskan Native populations. And so I didn't display all the maps here, but just to point out that there are other racial disparities at play as well. And this is just one to highlight that disproportionate burden that some individuals face. So when we do add violence to the picture, the inequities intensify. This is a figure from a New York Times analysis that used national data and showed that Black mothers, and particularly young Black mothers, are killed at much higher rates than other groups. And so you can see these bars, they represent pregnancy-associated homicide deaths per 100,000 live births across a 5-year time span. And so this first group up here, the biggest bar at the top, those are Black women aged 10 to 24 years old. And you can see that their rates of death are over 5-fold some of these other groups that are listed down below. To highlight the disparities a little bit more concretely, this slide shows that Black women, shown in this green wedge over here, make up about 14% of births, yet they account for over half of pregnancy-associated homicides, at least in our sample. And so over half, almost 60%, as you can see called out here, which is really striking. And so again, the danger is universal amongst pregnant individuals, but the burden itself is not. So moving from racial disparities to geographic inequities, I'll talk more specifically about our study now, which these maps are drawn from. They show rates of pregnancy-associated homicides. So this top map shows all-cause homicides in the pregnant population, and the bottom shows firearm-specific homicides. So overall, you'll see between the two, the patterns are pretty similar, which we would guess based on our discussion earlier about how firearms drive these overall homicide numbers. We did find wide statewide variation, and you can see that by these gradations. So some states during our study reported 0 or very few deaths, shown in white or this light pink. And then it goes all the way up to a state that exceeded a 100 per 1 million live births, shown in the darker red states. And so becoming pregnant in, let's say, Louisiana carries a very different level of risk than becoming pregnant in somewhere like Massachusetts or Connecticut. Where you live fundamentally shapes your risk of homicide during pregnancy. So I think the natural question is, okay, what's driving that variation between states? Why is there such a striking disparity? And so that's what we sought to answer this. So this table shows the multivariable model from our study, where we tried to look at the association between pregnancy-associated homicide and rates of firearm ownership. So as you can see in the table here, we accounted for a number of state-level factors, including age, sex, poverty, unemployment, insurance coverage, and population density, none of which was significant in the model except for firearm ownership. And so you can see in this row highlighted in red the incident rate ratios of 1.06 for all-cause pregnancy-associated homicide mortality, and then 1.08 for firearm-specific mortality, which in simpler terms tells us that in our adjusted models, every 1% increase in the estimated state-level firearm ownership was significantly associated with a 6% increase in the pregnancy-associated all-cause homicide rate and an 8% increase in the firearm-specific homicide rate. So none of those other state-level variables that you saw were significantly associated with homicide in the model, telling us that among the factors that we could reasonably include in our model at the state level, the factor that consistently tracked with whether pregnant people were killed was firearm prevalence. And so in other words, without suggesting any causality here, it does seem that at least in part, geography matters, right? Because the firearm environment and ecosystem of availability is different from state to state. These are those same results just shown visually. And so here you have the x-axis is the percentile of estimated state-level household firearm ownership prevalence, and the y-axis is the estimated homicide rate. Again, the all-cause homicides are on the left, and then the firearm-specific homicides on the right. And you see a stepwise increase in those homicide rates as ownership increases. All this is to say that even incremental increases in firearm availability appear to translate into pretty measurable increases in the risk that a pregnant person will be killed. And so now we've talked about the what, right? The scale of the problem, who is most affected, and some of the disparities that are embedded within, some of the racial disparities, geographic disparities. And so let's talk about the potential drivers, the potential whys. I would say these deaths don't happen in a vacuum, but are driven by many and at least four overlapping forces. And so I'll talk about these four today. We'll go into each of them one at a time and then talk about potential solutions or at least kind of interventions for each of these drivers. So first, we'll talk about intimate partner violence, or IPV, structural racism and systemic inequities, firearm policy and legislation, and then data gaps. So first, IPV in pregnancy. IPV is more common in pregnancy than preeclampsia or gestational diabetes, but I would argue that we rarely talk about it or at least treat it with the same clinical urgency. More than half of peripartum homicides are committed by current or former partners. And just to say again that this is likely an underestimate due to a lack of accurate data sources. And then this was kind of a seminal study back in 2003 by Campbell et al. That found that when a gun is present in an abusive relationship, the risk of a woman being killed increases fivefold. And so firearm access doesn't just change the method of violence, but really radically changes the lethality of that violence and changes the likelihood that someone will be killed by that violence when it occurs. So I think there are several parallel opportunities to reduce firearm homicides in this population that mirror those underlying four drivers. And so first, we'll talk about IPV. I think we can address some of it, at least through clinical interventions. Prenatal and postpartum visits provide frequent touch points and trusted opportunities to screen individuals for intimate partner violence and to ask questions like, are there firearms in the home? If so, how are they stored? This was a study, it's several years old now, so rates may have improved, but at that time, estimated IPV screening frequency was only at 22%, and so definitely tells us that there's a lot of room for improvement there. ACOG already recommends integrating firearm safety counseling into intimate partner violence screening, but I think even screening outside of IPV just for the presence of firearms in the home and their safe storage is important, since we know that safe storage reduces the lethality of violence. I think even outside of the obstetric world, right? Screening is important at the newborn visits, since so many of these homicides do happen during that postpartum period. And so not just during pregnancy itself, relevant to pediatric providers as well. I also think sometimes, speaking even or especially for myself, it's hard to know how to start those conversations. And so there are a lot of great tools out there. One of them is the AMA and Ad Council's recent collaboration on the Agree to Agree campaign. It's a digital resource hub with videos and toolkits and conversation guides, all meant to empower healthcare professionals or lay people to engage in conversations with their patients or with other individuals about firearm injury prevention. And so for those who are interested in the slides themselves, this hyperlinks directly to those resources. And then Brady is another organization that has some great resources on their website. And so again, I've linked their website here where you can go and sign up for the resource guide, which is specifically for healthcare professionals. Another thing I'll just say on this topic is that in case this is a hesitation or a barrier to initiating some of these conversations, is that there is evidence that culturally tailored firearm safety messaging is possible and acceptable across the political spectrum. So just to put that out there as well. I think OB-GYNs already counsel patients on sensitive issues every day. And since IPV is more common than some of these conditions that we do routinely screen for, we should be just as systematic and thorough about asking and then connecting people with resources, since it could truly be life-saving. So these are just some screenshots of those resources that I mentioned. So a screenshot of what Brady's website looks like, describing that resource guide, and you can put in your information and just download it. And then this one is the Agree to Agree website. So it has a lot of rich resources. This is the more user-friendly version. And so you can see the yellow drop-down and the blue drop-down. You can put in who you are and who you want to talk to, and then it'll come up with a bunch of different resources. And then here's more of the interface for healthcare professionals. And so you can kind of see on the left here, you can narrow down by the specialty that's relevant to you and different risk areas. And then it comes up, this is showing 1 to 10 of 54 resources. So lots of different topics and resources and guides. And so a really great collection that's been curated if anyone wants to look further into it. All right, so we talked about IPV. The second driver that we'll talk about are the numerous structural factors at play. As we mentioned before, young non-Hispanic Black women bear the highest burden of these homicides, and they face complex and compounding inequities. So our study on firearm availability and the significant association with homicide suggests that risk is shaped not only by individual factors, but also by broader systems of inequity, right? So beyond our findings on firearm availability being one such systemic factor, there are so many other things that influence risk, things like housing segregation, economic marginalization, underfunded community resources, and so on, such that pregnancy in this country is not just a biological condition, but rather a social one that's really deeply shaped by policy and by power. So what can we do about it? I think if the risk is created by systems, then the solutions also have to be systemic and multifaceted. So first, for pregnant individuals themselves, we mentioned formalizing universal prenatal screening for IPV and firearms, but that screening only works if patients can also access resources, right? So things like safety planning, shelter, legal support, mental health care, insurance coverage, right, for prenatal and postpartum care and follow-up. All of which, just to say, is being challenged in the country right now with closure of reproductive care facilities, things like the upcoming Medicaid cuts. And so really important for us to continue to advocate for these supports. And then one more note just on that postpartum follow-up piece. There was a recent study that was published earlier this year by Dr. Maeve Wallace and her colleagues that broke down deaths during pregnancy versus postpartum. And they found that 51%, so about half of pregnancy-associated homicides, occurred during pregnancy, and the remaining were within that first year postpartum. So at least in their sample, it really highlights that continued vulnerability into that postpartum time period. And again, the importance and relevance of not just obstetric providers, but also pediatric providers and any other individuals who interact with the family after birth, and the opportunities those people have to screen and to counsel and to have these conversations. On the community side, investments in things like housing. So just as an aside, I had done a prior study that looked at historical redlining and its association with present day firearm violence. And we found that areas that were redlined almost a century ago still had about 6 times higher fatality rates than in the quote unquote best designated areas, which really emphasizes the persistent effects of both discriminatory policies and housing disinvestment, and stresses the importance of investments in housing, in neighborhood safety, and economic opportunity. And so just as an aside, but all of those things reduce violence rates. And then just like any other public good, like clean water, like quality roads, I think safety itself should really be treated as such, as a basic expectation and a right, and something that we can invest in our communities. All right, so third driver is legislation and policy. So when we look at geographic variation, besides firearm ownership that we've talked about, differences in homicide rates also closely map onto policy differences. And so first, for firearm policy, we know from prior research in the general population that more restrictive firearm legislation is associated with reduced firearm violence. And so specifically, here are some of the policies that have been linked to lower deaths. Things like domestic violence related firearm relinquishment laws, and so requiring abusers to give up their guns. Extreme risk protection orders, or ERPOs. Those are court orders that prevent someone from possessing a firearm if they pose a significant danger to themselves or to others. And safe storage policies. These laws, as we know, vary state by state. So some have all, some have none, some have strong versions, some don't. And so a lot of variation, and something important for us to advocate for. There's also evidence that policies that influence access to comprehensive reproductive care greatly matter. So interestingly, states with more restrictive abortion access, for example, have higher rates of IPV-related homicides. And so again, not to get into any sort of causal statements, but the authors of that study did suggest that one reason for this might be because when someone can't end an unsafe pregnancy, the risk of fatal violence continues or escalates, right? So reproductive autonomy itself is a safety intervention and allows people to leave dangerous relationships earlier and on their own terms. All this to say, I think in both sets of policies, these rising deaths are not just, individual conflicts, but rather reflect policy landscapes. And I think since policy matters, then prevention is possible. So what can we do about it? I think really in our study, our results are not really incredibly surprising, right? If firearms are more available, then your risk of homicide is higher. And so approaches that reduce access to firearms for people at highest risk are associated with saving lives. Using our voices as clinicians, as researchers, as community members to vote for these policies, share the evidence behind them, and advocate to your circles for them. This is all a critical part of prevention and of protecting maternal health. I think that's what we can do in this space. All right, and the last driver I'll talk about is data gaps. So one of the reasons that this crisis has remained invisible for so long, I think, is that we haven't and we don't still count it well. Just as an example, in our study, we had to exclude 13 states from analysis due to insufficient data quality on homicides generally. So not just in pregnancy, just in broadly homicide data. And then of those included, in our study, more often than not, a death was coded as unknown pregnancy status. And so we counted those as no, not pregnant, just to bias our results towards the null hypothesis, since it was more likely that we then missed someone and undercounted pregnancy-associated homicides, but definitely a limitation in the data. And then finally, there's essentially no national data on firearm injuries during pregnancy. So if you look at this just kind of simple graphic, which tabulates firearm incidents that the organization Everytown has counted since the beginning of 2024, so January 2024 until I pulled this at the end of November, you can see that non-fatal injuries, this blue bar here, in the overall population due to guns were almost 50% higher than homicides in this red bar. So for every 2 deaths, there are about 3 more injuries. So again, we don't know the pattern in pregnant women, but we can infer that for every death of a pregnant woman that we mention here, there are likely at least several injuries that go uncounted. So these are people who survive the injury, but who suffer financial, psychological, physical morbidities, and their family members who also suffer, right? All of whom we undercount or don't count at all. Just to say, this presentation is also not talking about suicides. And so the official numbers that I'm presenting here, although I would say that they're pretty striking, they definitely underestimate the true burden of firearms in this population in pregnant women generally. So what can we do in this space? I would say better data is not just something that would be nice to have, but is really rather a precondition for accountability and advocacy for effective policy. So maternal mortality review committees, or MMRCs, they exist in every state to identify causes of maternal death and recommend prevention strategies. They've been instrumental in the past in improving clinical causes of maternal mortality, but for violent deaths, the system breaks down. So pregnancy status is often missing from death certificates or police reports. And then on the flip side, many states still don't classify homicide as a maternal death in their formal review process. So this is a great editorial that was published that calls for MMRCs to systematically collect pregnancy status and then count them as maternal deaths so that these lives really aren't just erased. I think when something's not measured, it's easier to ignore it. And when it is, it becomes more real and visible and actionable. And so I think to prevent these deaths, we need stronger MMRC requirements to capture pregnancy status and to count homicide as part of maternal mortality. And then increased federal funding for surveillance systems, things like CDC's National Violent Death Reporting System, or NVDRS, which we used for our study, just to improve completeness and really capture that data for further research and future advocacy efforts. So we talked about 4 drivers. There are many more, but what I hope is clear by now is that this is not a single issue or a single solution problem. Pregnancy-associated firearm homicide sits at the intersection of multiple overlapping crises that we've talked about. So it's a maternal health crisis as the #1 cause of maternal death, public health and violence crisis with firearms really driving these homicides, a racial equity crisis given the disproportionate burden on certain populations like we talked about, a reproductive justice crisis with policy really determining who gets to be a mother, and a crisis of data and accountability, as we just discussed. And I think underneath all of that is this moral crisis about whose safety we have been prioritizing and whose we should be prioritizing. We are failing mothers and their children because we choose to. And because these circles overlap, no single intervention is going to be enough. We need clinical action, community investment, policy change, and better data all moving in that same direction. So just to bring this all together, some takeaways. First, again, homicide is now the #1 leading cause of death during pregnancy and the early postpartum period in the United States. So that itself is really striking. Second, firearms are driving the majority of these deaths. So that's not an incidental finding. That is the dominant mechanism of lethality. Next, this risk is not evenly distributed, as we talked about a bunch. We see profound inequities by race and by geography, with Black women, women in high firearm ownership states, or in states with less restrictive policy environments bearing a disproportionate burden of these homicides. And then finally, just to offer some hope and avenues for action, policy, prevention, and data systems are all modifiable levers in reducing these deaths. Just to end where we began, I think with the idea of what pregnancy should be, which is a time of support and hope, and not one of avoidable harm and death. The fact that in the United States, becoming pregnant can increase your risk of being killed by a gun is not an inevitability of biology, but rather a predictable result of our policy decisions. And so again, like I mentioned before, I think what's predictable is preventable. And so if we treat firearm violence amongst pregnant women as the epidemic that it is, if we count the deaths, if we name them, and if we act on that evidence, then we can protect mothers and their unborn children from becoming just more statistics. And then some key acknowledgements. This all takes a team. And so first and foremost to Lois Lee, my mentor and the senior author on our paper, Eric Fliegler, another of my mentors and co-authors, and then our other co-authors, Michael Monato, Gabrielle D'Ambrosi, and Suzanne McClone, as well as Boston Children's Hospital and Harvard Medical School for their support of my work, and of course, the UConn Arms Center and Yale School of Public Health for inviting me today. These are just references, and then this is just a true, again, heartfelt thank you for taking the time to listen and attend this talk. This is a picture of my daughter, who is one of my main drivers for this work and this advocacy. This is my email. I would love for anyone to reach out whenever, and otherwise that's all I've got, and would love to hear anyone's thoughts.
Amazing. Thank you so much for that. We are now, okay, look, the clapping hands are coming. We have amazing presentation as a comment in the chat. So I think we all loved it. I think I can speak for everyone. I mean, obviously not the punchline, but we loved your presentation.
Thank you.
So what questions do we have? I'm always game to ask a question, but you know. So you mentioned that the data doesn't include suicide in your results. I'm wondering if you have a sense of, if you did include suicide, how much your results might change, if at all, if that's something you and the team have looked at.
We haven't looked at that. I think that generally the takeaway that if firearms are more available, then the rates of death are going to increase would probably stand true. So we know from the general population that that's true for suicide, and so firearm ownership is associated with increased rates of suicide. So we didn't look at that. I think it's a different population altogether, but I do think that the findings and some of those action items definitely hold true.
I guess I'm also curious over time, right? Women's firearm suicide, it's sort of changing over time. So other questions? I asked a question so you could think, so you could get started. All right, I'm going to ask another one, but you should think of questions. So you told us what you think might work. I'm wondering if as you looked at other explanations or interventions, if you came across anything that you wouldn't recommend as an intervention to try to increase women's sort of natal and postpartum safety as it relates to firearms.
Yeah, that's a great question. I mean, I think overall, most of these things, just trying it and talking about it and bringing it up, I feel like would move us in the right direction. I think we have so little evidence on what works or what doesn't work. I think back to the conversation on policy, there are certain policies that don't work. And without going to all of the nuances of it, I know some of the domestic firearm relinquishment laws, when you just have laws that either one or the other, if you force abusers to give up their guns but don't prevent access to it in the future or vice versa, then those policies aren't as effective. And so I think there are some nuances to the policies that we advocate for. And then of course, policies that are, less restrictive on firearm legislation are ones that we shouldn't be advocating for. I think otherwise, I think because there's so little evidence and so little that's talked about, just having these conversations in general seems to all be kind of moving us towards at least raising awareness, which can push us towards policy and advocacy, and very little on the counter. But of course, would love to hear from others if there are things that people think might not be as evidence-based to support.
We'll let people chime in with those, but we do have a question in the chat. And again, you're welcome to pop questions in the chat if you're someplace where you can't come off mute or video. So the question in the chat comes from Heather. In your research, was IPV a leading driver of increased mortality over policy, or was everything interwoven? I'm thinking from a clinician point of view, Heather's nurse, and how I can best assess my patients.
Yeah, so I love that question. I think the short answer is our data, we didn't separate those things. And so we didn't look at specifically which of the homicides in the pregnancy-associated homicides were due to IPV specifically. And so we were looking at the state level and didn't look at the individual IPV data. And so I think, I know this isn't a great answer, but I would say that everything is probably interwoven. And I think if I'm understanding your question correctly, I think getting at both of those things are really important. I think as a clinician, probably the most actionable thing or most immediate thing is getting at the IPV piece of things and just making sure to screen universally and really address firearms as the piece of that. And so I think that would probably be first and foremost, but obviously using your voice to advocate for policy, I think is important. But yeah, great question. We just didn't break it down more specifically by either of those factors.
Thank you. And Heather says thank you too. So from Woody Kessel, Woody says, I may have missed it. How does trimester affect the untoward consequences? And please comment on maternal death and fetal death.
Yeah, so I mean, I think that's a great question. I would love to know the answer to kind of trimester specific risk. All the stuff I brought up about the barriers that we have in data, we can't even capture pregnancy status well. And so we have no data on, trimester specific risk. And so in NVDRS, it basically says just pregnancy status is pregnant or not pregnant, pregnant or pregnant within the past year, or unknown or not pregnant. And so gestational age or trimester is completely missing. And so I can't really stratify risk by that. And so we basically can just say that there's elevated risk across the entire pregnancy and postpartum period. But I think it's a really important question and would be really interesting to be able to, obtain data on that.
Yeah.
And then the maternal death and fetal death, I don't know if you're asking, I don't exactly understand that part of the question.
What do you want to clarify? I know you're not shy.
Like we don't have data, similarly to, we don't have data if a death occurs later in pregnancy, we don't have data on whether that fetus survives or not. We have none of that data. Again, would be interesting, but so many areas for further research and data collection, I would say.
Yeah, you did a super job on all of this, and it just raises questions that we've been struggling with for a long time. A maternal death typically equals a maternal death, and a fetal death.
Mm-hmm.
And that gets into the complexity, particularly not from the public health per se, but from the criminal and the legal perspective, how that gets handled, and then it gets into the complexity of the age of the product of conception, in our terminology. But I just was curious about whether you found anything in reviewing any of this, that this is, to put it in the vernacular, a double homicide.
Yeah, no, absolutely. I think it's a great point. And we didn't frame it as such, but I do think it's a very powerful way to phrase it or frame it, to use that kind of in advocating for these pieces.
Just to clarify, do you have a sense of how many were in? And I'm sure you said that this was a lot of information, so I apologize. I feel silly asking this, but do you know the breakdown of how many deaths occurred while the person was still pregnant versus postpartum?
Yeah, so there was that study that was published in 2025 by Maeve Wallace, who does a ton of the research in this space. And she said that of their sample, 51% of deaths occurred during pregnancy, so basically half and half,
Okay.
At least in their sample. And again, their study was amazing, but there are data limitations to that. And so I think that's the best data that we have to say that's still, which is also why I think the emphasis on, pediatric providers and other providers are just as important, because there's still such an important window of vulnerability after pregnancy is over that we can still screen for and try to intervene in.
Yeah. And then of course, like just following on Woody's point, right? If a homicide happens in the postpartum period, it of course doesn't mean that other members of the family or around that female victim weren't also killed or injured, right? Someone who studies domestic violence, you commonly see, unfortunately, multiple family members in a homicide. And so that also gets a little tricky. It could be more than a double homicide. It could be a homicide suicide. It could be lots of things.
Yeah, no, absolutely. I mean,
Driving home that we need more data and to
Totally.
further depress us a little on a Tuesday afternoon, depending on what time zone you're in.
No, absolutely. No, I think that's so, so true. And the data on that would be really interesting and informative. And I think just to also get at my point about the, undercounting, I think in those cases, like even if it's not a double homicide, if it's happening in the postpartum period or during pregnancy, right? Like you're leaving so many family members behind potentially, and the financial costs, like just the ripple effect of all of those costs of the firearm violence itself, I think is so unmeasurable, or at least difficult to measure. And kind of unfathomable, all those ripples effects that we don't talk about, that I think is also part of this equation.
Yeah, um, for sure. So Mickey Spurlick has a question that's actually like related to a question you got when you first started, which is terrific presentation. Are you open to sharing it? I would like to share with my PhD students. And while we're on the topic, there was a question that said, I run the social media for a healthcare gun violence prevention advocacy group. Is it okay to share screenshots of your slides? And I said to take the screenshots, but to ask permission before we shared them. But the other thing I will say to everyone is that, as you know, this presentation was recorded. You hit the record button, and it will be on both the UConn Arms and Yale School of Public Health websites. And so you can always access the recording link there. We'll put it out on social media and share it. So there are lots of ways to share the presentation, but Ayesha, I'm going to let you now comment on the general idea.
Yeah, no, I feel free to take information from this. I'm happy to share slides with anyone.
Great.
Thank you. Yeah.
And of course, the tribute. So then I have another question, which is, do you have a vision for how we can better elevate patient stories to incorporate into firearm safety advocacy for pregnant women and children?
Yeah, I think that's a great question. And I think similar to, in other spaces of firearm violence advocacy, not just in pregnant women, I think figuring out how to do it kind of ethically and in partnership with patients would be really important. So I think, I was grateful to pull 3 women's stories from the media, but I think the most powerful stories come from survivors and their families. And so I think we need to figure out, how do we create trauma-informed storytelling pathways, right? Like how do we elevate the voices of patients or families who do want to share their support stories, and how do we support them in that in ways that support them but don't re-traumatize them? And so I think that would be kind of one of my big visions, is really just elevating community voices and survivors' voices, which I think is a whole nother topic and, space for advocacy. And then I think, similar to what I was kind of talking about, I think stories are most powerful when they're paired with the data. And so just being able to share this data with you all and have you take that data and share it elsewhere in your networks, I think is, part of the vision of spreading this message and elevating its importance. And I think as clinicians, a lot of times, protecting our patients and keeping them anonymous, and then figuring out how to, as physicians, use our voices and tell those stories that we see is also really important. So I think all of those 3 things, if that gets at your question, there are ways that we can, tell these stories and make sure that we do due diligence to the people who are most affected.
From Molly, I apologize. I'm not even going to try to say your last name. She asks, beyond improving our universal screening for risk factors like IPV, firearm access, I'm curious if you came across anything else that should flag for us as indicating risk for specific patients, like frequent ED presentations for either parent, baby, etc.
Yeah, I mean, I think can't cite any specific literature, but I think in the general firearm violence space, right, there's a lot of things that I kind of mentioned are tied to risks for violence, and a lot of those are structural things. So things like housing insecurity, lower prenatal care, lower care in general, mental health care utilization. And so I think anything that indicates that someone is suffering potentially from like systemic inequities or other inequities and decreased access to care should all be kind of flags, but obviously take that with a grain of salt because I don't want to introduce any bias in terms of, because those things go hand in hand, right? Like seeing a patient who is has a language barrier or a cultural barrier or has housing insecurity is obviously at disadvantages elsewhere, but not taking that as a specific, like you should be screened more, if that makes sense. So I think those are risk factors just because of the structural ecosystem in which they are, but I think it's hard to like use those specifically. And so that's why I kind of advocated more for a universal prenatal screening.
Do we have other questions? Oh, Lois, please.
So I would maybe put this question back out to the group. Like, I'm glad all these people were interested in our work, but this is obviously an important message that needs to go out to families and to, clinicians. So, are there ideas or suggestions for people to understand this highlighted risk and what are both in the individual and sort of societal solutions that need to be addressed? And maybe, Carrie, I'm asking this question to you as being someone, we are in the pediatric space, but how do we reach out to obstetricians and gynecologists, family practitioners, and those who are in sort of adjacent spaces?
Yeah, so this is like my colleague Jen Deneen, who we imagined the seminar together, and unfortunately she couldn't be here today due to a personal family issue. We wrote a paper about sort of doctors talking about actually ERPOs with their patients, but I think this like extends a little bit. And in the obstetrician space, obstetricians in our small study, which is qualitative in nature, limited to New Jersey. So like, I want to put all the caveats on that. And I've not like freshly read the paper in expectation of your question, Lois. Right. But they said like, why should I ask my female patient about her husband's gun? And so like, there are a couple of things in that term that I think go to this like broader education. And one of the reasons why, for example, this seminar is open to everyone. Like we don't limit who can come to the seminar. We don't pitch it to one group of people. And I love seeing the different diverse folks that come on each of these calls. But right, like number one, women can own firearms. Like I just want to put that out there. Like it's not whatever 19 number anymore. It's 2025. And women can and do purchase their own firearms. Her firearms in a home need not belong to a husband or a male figurehead, but could in fact be the woman's own firearm. That's a whole different conversation and those rates and changes in trends. But also this idea that like, I think to Ayesha's point that like, we often don't see sort of partners, spouses, et cetera, as potentially like part of the danger that a woman might face, right? We kind of, it just goes against our cultural norms and expectations in a whole lot of ways. And this, I think, is important for the universal screening aspect is you don't know what goes on in someone's personal life and the risk factors that they may or may not, sort of have. So I think this universal conversation, I think continuing to have this conversation, I'm going to the Hill actually Wednesday and Friday, and I'm going to put this on my list of things I talk to the congressional staffers about. So I think it's just all up to each of us in whatever aspect we're going into to carry the message of this and others. The other thing, I'll put a shameless plug in. So Jen and I, along with Vital City, are bringing about a special issue about women and guns just generally. So Ayesha has contributed a paper to that issue. So this will be in there, but also just the distinct ways that women face danger or injury from guns generally in our society and the way that might look different than their male counterparts, or the ways it might be the same. So look for that in spring of 2026. It will be totally open access. Vital City is a jargon-free publication, so very accessible to lots of audiences, though still written by great experts and leaders in the field. So I guess I would say keep talking, read everything you can, and like let's put our assumptions about who might be at risk aside, because those might be creating, to Aisha's other point, more danger in and of themselves. I'm sorry, that's not super satisfying. But if others have satisfying answers, I talked for a long time. So you should now be able to answer Lois's question. So Heather says, yes, and I love this. Students are the place to start. We teach our preceptors just as much as they teach us sometimes. Absolutely. And I would add on to that, not just educating the next generation, but this generation, right? Those we're all students. Let's all be lifelong students and open to learning. But I love this idea that education is co-produced, right? We learn from our students learn from us, etc. Chris Ross says the lack of awareness on domestic violence in teenage relationships is crazy. The things I have seen in that 14 to 18 age group is crazy. Yeah. Young people. I have one at home. He might have broken his hand earlier, so I've got a young person home. Yes, they do all the things. But yes, we tend to underestimate the lethality of dating relationships, of cohabitating relationships, and we've got some good, I think, emerging literature that I think speaks to some ideas that people have had for a long time, but is sort of confirming it in a causal and rigorous way, that dating and cohabitating relationships may be especially dangerous relative to sort of more marital unions. And I think there's a lot of reasons for that. Who's selected into those unions, why certain unions make it to marriage, but may stay in cohabitating and dating. There's a whole lot of things, but yes, the younger cohort is particularly vulnerable, which goes into firearm access among our younger folks, right? That's a different policy and a different conversation. But to Aisha's point about all of this being overlapping and interwoven, and that there's not one particular solution, but lots of different ways that we have got to think about tackling this issue. Ayesha, I'm going to give you the last word. We've got a few minutes left of this seminar. I feel like it's only fair to turn it back over to you and let you close us out.
Oh, I don't have much to add. This was so wonderful. And thank you guys for the opportunity to talk to you about this. I think it's such an important issue. And, before I started the study with Lois, didn't realize how much of an issue it was. And so I'm humbled to be able to do it. And I think, just really grateful to share this. Definitely reach out if you have any questions or thoughts or other advice in this space. Would love to hear from you all.
Fantastic. Thank you, everyone, for joining. Please join us back in January for Dr. Middlewood and all of our other On Target presentations. And I hope you have a great rest of your day, wherever that may be. Thank you.
Thank you all.